Thank you very much for that kind introduction. Can you hear me okay? I'm a mother, so usually you can project. Okay. I would like to first thank the University of British Columbia School of Nursing for inviting me to give this Marion Woodward lecture. It always produces a little bit of additional pressure on you when a lecture is named after someone because you really want to do them and their memory justice. So I'm hoping that I can do that this evening. I've had a wonderful day here. I got to hear about three wonderful projects that are going on with nurses, and I really enjoyed that. And also have had time to socialize with some of the faculty here. And the project that Helen mentioned that I do across pediatric hospitals in Canada, the BC Children's Hospital was one of those hospitals, and so I've gained many friendships and colleagues there. So tonight I'm going to really focus on the problem, as I see it, of taking what we learn from research and making it into something useful for both clinicians and policymakers. And I will take my own research experience and interject that to try and make this a real live situation. First of all, I'll disclose that I don't have any commercial interests except with publishing companies. My funding is through the Canadian Institutes of Health Research and Grand Challenges Canada, which is the Canadian arm of the Bill and Melinda Gates Foundation. I'd also like to acknowledge my PhD and postdoc students who have actually worked on this research project. So this is where I come from at the University of Toronto. It was nice and sunny and blue like this today there, I'm told. I'm lying, don't worry. And I also do work at the Hospital for Sick Children, and last fall had the privilege of moving into the Peter Gilgan Center for Research and Learning, which is a 22-story research building. And I think what is important with this is that on the 6th floor where I'm located, they are in the midst of doing a natural experiment where they've mixed together the basic researchers, the clinical researchers, and the knowledge translation researchers to see if we will actually meet at the water fountain and share ideas. So when we think about where we're at with the healthcare system in Canada today, just to set the stage, we know that we have approximately 300,000 nurses, compared with about 77,000 physicians. So there's really only one physician for every 4 to 5 nurses. We also assume that good health care and universal access is a right, and our government spends healthcare dollars only second to the United States. So it would appear that we have a very good healthcare system or a very good situation. However, we know that universal health care is mostly related to physician access and hospitalization, and we don't really have one national healthcare system, but rather 10 disparate systems. We also know that 1 in 6 Canadians do not have a regular care provider. We know that 1 in 12 patients who are discharged from hospital are readmitted. We know that approximately 20% of the population is obese, and this is concentrated largely in young people, and about 20% suffer from chronic pain. So these are some of the key health conditions that we need to focus on as we move forward into the future. However, the good news is that nurses are ideally positioned to affect patient and family outcomes at the individual or consumer level, the organizational level, and also at the health systems level. Nurses the healthcare system's best unleashed power. And this was brought to light by the president of the Canadian Nurses Association, and she particularly singled out nurses from the North, who she said are doing an excellent job in re-imaging nursing in Canada and refocusing on health promotion and refocused on community care. The process of changing healthcare provider practice, however, or system effectiveness, efficiency, economic and policy outcomes, is not easy. However, it is underpinned by a conceptual and theoretical basis of change and implementation science. So my goal this evening is threefold. First, we're going to review the strategies indicating how research and knowledge can be translated for effective change practices and outcomes using the clinical problem of pain for hospitalized patients as an exemplar. I'm going to identify issues related to evidence, context, facilitation strategies, and knowledge translation processes and sustainability. And finally, I want to articulate how theoretically driven implementation science can influence impact at the individual, organizational, and health system levels. So let's talk about pain for a moment. Most of you will know about pain. Either you're a pain sufferer, or you know somebody, or there's someone in your family who is. When we look at the numbers, 1 in 10 patients report pain after surgery, cardiac surgery, 2 years later, and 4% describe this pain as moderate to severe. Up to 50% of individuals endure persistent pain after common surgical procedures. This pain is severe, again, in 2 to 10% of cases. Persistent post-surgical pain represents a major and largely unrecognized problem in Canada. And again, approximately 10% of patients on wait lists for treatment at Canadian pain clinics identify surgery as their cause of chronic pain. When we look at chronic pain more closely, we find that 1 in 20% of adults suffer from chronic pain. Worse still, 1 in 5 Canadian children have weekly, persistent, or chronic pain, with 5 to 8% that's severe enough to interfere with schoolwork, social development, and physical activity. About 65% of seniors and 80% of older adults in long-term care facilities experience chronic pain that is most often under-recognized and undertreated. In the United States, the cost of chronic pain in adults, including health care expenses and lost productivity, so both the direct and indirect costs of pain, is between $560 and $630 billion annually. Using these figures, we estimate that the annual cost of chronic pain in Canada is $56 to $60 billion. So this is a huge problem, both at the individual level and at the health systems level. So how are we going to address this pain? One of the key strategies is through research. And we have basically 2 kinds of research that we're thinking about this evening. One is clinical research, and this is aimed at improving the diagnosis, treatment of disease and injury, and improving the overall health and quality of life of individuals across the lifespan. We also have health services research, and that's aimed at improving the efficacy and efficiency of health professionals and the healthcare system through changes to practice and policy. Health services research is a multidisciplinary field of scientific investigation that includes studies on how social factors, financial systems, organizational structures, and processes, health technologies, and personal behaviors affect access to health care, the quality and cost of health care, and ultimately Canadians' health and well-being. We also have basic science research that looks at the underlying mechanisms, but I'm going to really focus on these two types of clinical and health services research this evening. The model that I really like to use that looks at how we get the results of research into practice was developed by a nurse by the name of Alison Kitson from the United Kingdom. This is called the PARIS model of research, and PARIS is an acronym for Promoting Action on Research Implementation in Health Services. And I like this model because I think it's simplistic in that what it really proposes is that the interface between high-quality evidence, the context or the climate where we try to integrate that evidence, and the method of facilitation will lead to improvements in outcomes. I just want to point out here that research consists of more than the type of research that we see researchers doing all the time. It takes into account the clinical experience, the patient experience, and the local data or information. And that is the way that we do things around here. Facilitation really refers to the purpose of doing something, the role, and the skills and attributes. And finally, context really takes into account the culture or climate, the leadership support, the evaluation, and the resources. So all of these things go into the building blocks of actually changing and implementing research into practice. Globally, billions of dollars are spent each year in the public and private sectors on these different kinds of research, as well as healthcare professional training and continuing professional development, quality improvement, patient safety, and risk management. A consistent finding from clinical and health services research is the failure to effectively translate this research into practice and policy. So although we're spending all of this money on research, it's not all reaching the patient. Patients do not benefit optimally from new evidence, and 30 to 40% of patients do not receive treatments of proven effectiveness. What's worse still is 20 to 25% of patients receive care that is either not needed or potentially harmful. So what is the significance of all of this, especially in terms of health services, research, and clinical practice? If we could do this better, we could be advocates for social justice and equity across both provinces and population. We could improve the access to quality care across healthcare providers. We could focus more on health promotion and patient and family experience. And also we could determine the right indicators. We currently have too many indicators that create something called indicator chaos. We need to pay more attention to what patients want and need. So I'm going to give you a little quiz now. I want to make sure you're all awake. So this is a multiple choice question. So translating research results into practice, which is true? A, 50% of research studies are completed. B, 30% of research studies are published. C, studies with positive findings are 5 times more likely to be published than studies with negative findings. And D, bias exists from low internal validity, low external validity, selective outcome reporting, and conflict of interest. And the right answers were published in very reputable journals here. So which is true? All of them, exactly. So you can see the biases that creep into not only the conduct of research, but the publication and reporting of research. So when we think about it, when we make decisions about clinical practice, We used to make these based on single studies, but we now know that the body of research is escalating exponentially. So we can really look at systematic reviews of the evidence to clearly be able to determine what the best strategies are. Jeremy Grimshaw, one of the leading experts of knowledge translation in Canada, says that the systematic reviews are the basic unit of knowledge translation. However, we've learned that the road to inactivity, to change, is littered with research reviews, reports, and guidelines. So although we're systematically evaluating this research, we aren't necessarily using it. So what is this construct called knowledge translation? The CIHR defines it as the dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians. Grimshaw says that it's ensuring that stakeholders are aware of and use research evidence to inform their health and healthcare decision-making. Now, our Canadian Institutes of Health Research recently looked at the relationship between clinical and translational research. And those of you in BC understand mountains and valleys. So you can see that there are valleys, which they called valleys of death, which where research results were landing and dying. One between biomedical research, or the basic research and clinical science, and the second between clinical science and clinical practice and health decision-making. I'm really only going to focus on valley number 2 tonight. And this is what these types of KT research really relate to. Now, I said in the beginning that knowledge translation had a sound theoretical and conceptual background, and some of these theories aren't new. This is the theory of diffusion of innovations, which really looks at how we can implement an intervention or innovation. We know that there's what we call antecedents or receiver variables that influence the intervention, as well as processes of implementation and consequences of that. This is a model that has been around for a long time, but one that is still relevant today. CIHR has another model, and this is a knowledge to action cycle. And what's really nice about this model is in the middle, we see the creation of knowledge. So even though we may think we've learned a lot about an individual area of healthcare, there's always new things coming onto the horizon, and we need to always embrace that and engage in it. But we also need to engage in the process of taking that knowledge and implementing it into action. And if you look at the action cycle that circles this model, you'll see that it's very similar to nursing processes that we've learned about since the 1970s. What's newer, though, is the focus on quality improvement. So this is really a systematic approach to making changes and changing behaviors that lead to better patient outcomes, stronger system performance, and enhanced professional development. It draws on combined and continuous efforts of all the stakeholders. That's healthcare professionals, patients and their families, researchers, planners, and educators, to make better and sustained improvements. Now, many of you will have seen this model for improvement, and it really, again, looks at creating aims. What are we doing? What are we trying to accomplish? How will we know whether we have accomplished it? What measure will we use? And what change can we make that will result in an improvement? Also, at the bottom of this slide, you can see the characteristic Plan, Do, Study, Act cycle, or PDSA. And these are the hallmarks of quality improvement. So basically, it's creating an aim, figuring out where we are at the moment, figuring out a strategy, and then implementing it in this cycle and repeating it over and over until we reach our goal. So I want to give you an example of how we use quality improvement at the hospital where I work, at the Hospital for Sick Children. And we really wanted to improve pain assessment and management, which ultimately would improve pain intensity. Children would have less pain, and parents and children would be more satisfied with care. So in this model, you can see where we really focused at various levels of the hospital hierarchy. We focused on the hospital unit to improve quality improvement practices. We have a pain center that I'm the co-director of, so we really wanted to go across units and through the pain center to look at improvement in processes and clinical outcomes. And then the hospital was very interested in improving patient satisfaction. So our quality improvement strategy focused on all of these areas. When people ask me, how do you engage the hospital? Well, we went right to the top. We actually engaged the CEO, and she really put this in the hospital corporate scorecard. And as you can see when we drill down, this fit under patient and family-centered care. And there were priority 1 indicators in that, of which physical comfort and pain were one. And our goals were to continue to improve patient and family satisfaction with pain management, which we actually used a measure called the NRCC picker. And this is used to measure pain satisfaction across hospitals, across countries. Within that measure, there's 5 questions that relate to pain. So we really wanted to know, was the pain the child experienced in the hospital more than what they thought it would be? Did the doctor or nurse ask your child questions about his or her pain? If you or your child had to ask for pain medicine, did doctors or nurses respond quickly to your request? Overall, how much pain medicine did your child get? Too much, too little, the right amount? Or do you think the hospital staff did everything they could to help control your child's pain? So these are the kinds of things that are the indicators of satisfaction. And we kept track of the results on a corporate scorecard. And when we pulled out the pain satisfaction, you can see that this has gone up and down over the past 6 or 7 years since 2008. But when we started the QIP plan in mid-2012, you can see a sustained increase. So this is an example of how quality improvement can help improve both practice and individual outcomes in a hospital setting. The other big project that we engaged upon was the CIHR team in children's pain. And this was a national project that really looked at how we could better implement evidence into practice. We used the same conceptual model, the Paris model, that I explained to you earlier. This project was carried out on 32 hospital units in 8 tertiary pediatric hospitals. 16 units received the knowledge translation, the EPIC intervention, and 16 received standard care. The EPIC intervention was 15 months long. It included multifaceted knowledge translation interventions in 4 3-month plan, do, study, act. So we kept repeating. And we had a little break in the middle to do audit and feedback between cycles. EPIC is not a difficult intervention to understand. There's a preparation phase, and all of you know that preparation is where it all happens, where we established a team of champions. We trained them on clinical and research evidence, effective knowledge translation strategies, and quality improvement methods. We reviewed the baseline data to identify potentially useful practice changes. We reviewed the existing clinical and research evidence to support a practice change. And then we made a decision on what the practice change would be and how to develop an aim statement. We then felt we were ready to move into the implementation and change phase, where we did a pilot test of the practice change using knowledge translation strategies, things like reminders, educational materials, educational outreach, and audit and feedback. Then we implemented the practice change, doing the plan, do, study, act cycles, and then we evaluated where we were and started all over again. These are some of the knowledge translation strategies that were developed for this project. It's always wonderful when you work with children because much of this was through children's art, and they helped us develop these strategies that we used in many hospitals. We had over 300 of them, and these are just a few. Now, how effective are these strategies? I just recently reviewed this paper by Grimshaw, and he looks at various knowledge translation strategies that are geared towards healthcare professionals, consumers or patients, and policymakers. And the ones that are bolded and in red really indicate which ones are actually most effective. You can see that most that are effective are directed towards healthcare professionals, with a few effective ones for consumers and patients, and really none that have been shown to be effective for policymakers. So you can see where the gaps are and perhaps why we're frustrated with policymakers and their decision making. This just gives you an idea of the 5 years that we actually undertook the EPIC study. So you can see in the middle the PDSA cycles, and we also then did data collection both at baseline, immediately following the intervention, and a year later to see how things were sustained. This gives you an idea of some of the results. So we were really able to impact the proportion of children who were receiving the targeted pain practice. And you can see it nicely rose over the 4 cycles. And then you see it sort of plateauing at the end of cycle 3 and 4. We did another study to look at the sustainability of these changes a year later. What do you think happened? So people are kind of going like this. So this was an expensive study. This study cost $5 million. And although it was very successful in changing practice, what we found when we pulled all the research dollars, the researchers out, was kind of surprising actually. We found a third of the units stayed the same. They continued to maintain the practice changes, or some of them even got better. We found about a third of them fell off their progress, but not by much, by about 10-15%. And a third of them did what you thought. They went back to square one. So we're in the midst right now of trying to look at those units that did either well or poorly to see what are the characteristics of those units. We think context is really important, and I'll talk about that in a minute. What we also learned, though, is that effective KT strategies are not passive. They're not handing out written materials. They're not sending somebody off to the library to read a paper. They're all about engaging the stakeholder. And you can see here, this is called the daily huddle. And this is a bulletin board on a unit where nurses and other healthcare professionals go for 2 or 3 minutes in a 12-hour shift just to look at one piece of evidence and try to figure out ways to incorporate that into their practice. Because really what works in knowledge translation is to integrate the changes within processes of care. People have to feel that they're doing this as part of the normal daily care that they do. We offer healthcare provider orientation and education. This is also instituted in institutional or public health policy, clinical practice tools or toolkits or toolboxes, consumer and patient family education, and social media. But we have to ask, what should be translated and to whom. We have to identify key messages for different target audiences and fashion the messages in a language and knowledge translation product that is easily assimilated by different audiences. Different messages and products for targeting different audiences include things like decision aids for patients, clinical practice guidelines for healthcare professionals, and actionable messages and policy briefs for policymakers. I want to share with you an interactive health communication application. This was developed by my PhD student, Dr. Jennifer Stinson, and I think it will give you a really good idea of what can be accomplished when a message is targeted at the right audience. And this message was targeted to children and their families with cancer.
This is the Hospital for Sick Children in Toronto. Within these walls every single year, thousands of children are battling cancer and are having to undergo terribly painful treatments. Children like Olivia, who 8 months ago was diagnosed with Ewing sarcoma. The hospital is continually trying to minimize this pain, but to do it, they must first understand it better, and most importantly, discover the medications that are working best. To do this, they need these young patients to record exactly how they're feeling in a pain journal. The challenge is that after multiple chemotherapy and radiation treatments, many kids are too tired or discouraged to even hold a pen, much less keep a detailed journal. And the sad reality is that if this data is not collected daily, it's useless. We needed to find a creative solution to collect data every single day, and with the Pain Squad mobile app, that's just what we did. To begin, our patients were enlisted as recruits in Pain Squad, a special police force dedicated to hunting down pain. We gave each recruit an Apple iPhone loaded with the Pain Squad mobile app. Then twice a day, an alert from headquarters told patients it was time to complete their pain reporting mission. Because the reports worked with iPhone's user-friendly touchscreen, kids could easily fill them out. With a simple flick of the finger, they could identify exactly where and how much it hurt, as well as which medications were working best. But making it easy was, well, the easy part. We knew to be truly successful, we needed to find a way to encourage our young target daily. So we called in some police reinforcements.
Hey, rookie. Welcome to Pain Squad. It's really great you're here. We need all the help we can get to help put pain in its place.
We brought together the casts of Canada's top police dramas, Flashpoint and Rookie Blue, and filmed a series of inspiring videos, then deployed them throughout the app. To encourage the kids to fill in their reports, we built in a graduation structure. When a recruit completed 3 reports in a row, they received a message from HQ informing them that they were moving up the ranks.
You are now officially a full-fledged detective in Pain Squad. Well done.
At this rate, you might even be the next chief.
They just don't make them like you anymore.
You truly are one of Pain Squad's best and brightest. Keep it up.
Back inside the precinct, recruits could check to see when to fill out their reports and how many badges they had earned. And once their last report was filed, they were sent one final message informing them that they were being retired from the field.
But this case isn't closed yet. Your squad is still fighting. We couldn't have done it without you. So way to go.
The Pain Squad app is now set to roll out into 4 other Canadian hospitals. And due to its success, it will soon be made available everywhere.
The app is an excellent tool. That's her control over the pain because she's able to document it herself, but she's using an app. She just glides right through it, and it makes her feel that she's a part of this. It's fantastic that you all were able to come up with this. It really helps.
Just got the word from Chief. Turns out you've been doing so great, he feels like you're ready to move up. You're well on your way to putting pain in its place. Don't stop now. You're almost there.
Congratulations. Sergeant.
So I think you can see how that positive messaging can really get the message across. I think it also indicates that we live in a new world of how healthcare is handled. And patients, these patients, come to see their physicians with all this data that they can use to translate into better treatments and management. The next phase of this work is to develop a decision-making algorithm that will actually point them at self-management strategies. And that's what Jennifer, who's now finished her postdoc and is a brand new research chair at the Hospital for Sick Children, is working on. So we want to improve outcomes within a changing and dynamic healthcare system. We've talked a lot about the clinical research, but we need to think about, from a systematic perspective, how we can build research and quality improvement capacity, how we can engage the public within healthcare research. I said earlier that we needed to talk to the public about what were the best indicators. We need novel programs and platforms for educational research. We need to understand this mysterious construct of context, and we need to evaluate impact. So I'm going to show you one more video, and this is about capacity building. And we've been fortunate to have a strategic training research program here in Canada called Pain in Child Health. It's a national program, and we also were fortunate to get money from the United States, from the Mayday Foundation, to include international trainees. And this is what we've been doing over the past 10 years or so to actually increase research capacity.
Despite all the advancements that we have made as a society, we haven't figured out how to do everything we can to help children with pain. Ask any parent whether it's okay for a child to be in pain, and you'll hear a resounding no. And yet, veterinarians receive 5 times more training about pain than doctors. On average, children in hospitals experience 6 painful procedures per day, many without any pain management at all. Untreated pain in children can produce long-lasting changes in their brains and bodies, make them scared of going to the doctor, and make them more sensitive to pain. 1 in 5 children has chronic pain like headaches and stomach aches, and many children will become disabled by their pain, missing school and hurting their relationships. Only 3% of children with chronic pain ever get access to the pain treatment they need, and 2/3 of children with chronic pain continue to experience pain as adults, costing society billions of dollars. We need to change how we think about and provide care for children in pain. Recognizing this significant need, the Pain and Child Health Program is working hard to solve this problem. Our community of researchers is focused on cultivating new talent and promoting new discoveries. We connect students training to be nurses, doctors, psychologists, and scientists from around the world, both online and in person, serving as a catalyst for better ways to help manage pain in children. Most importantly, we are building research capacity for the next generation so that fewer children around the world will experience unnecessary pain. We've helped turn Canada into a world leader in producing research on children's pain. In the last decade, our trainees have published over 700 peer-reviewed scientific papers. The people we have trained are based in more than 14 different countries, and they take their new knowledge in children's pain with them all around the world. But there's so much more we could do. We need to continue to work together to make a lasting international impact on children's pain, benefiting children's health and their futures. To learn more about our program, please visit our website, paininchildhealth.dal.ca.
So you can see this is 2 examples of getting the message out there. That one was directed towards healthcare professionals, potential funding partners, potential educational partners. So I think that the power of the positive message can be really amazing. There's also an opportunity to build capacity through written materials. This, you can recognize, came from the same producers of the video that I just showed you, and this is an infogram, very easy to put onto the internet. And this is another opportunity to engage with the public. This is called the Café Scientifique. It's put on by CIHR. And this one was held just a couple of weeks ago, where we actually met at the National Arts Center in Ottawa to actually have a session with the public to talk about pain. Another way of learning about how to best engage or translate research into practice is through talking to healthcare professionals. So this is a booklet that was made by interviewing healthcare professionals. It's called Stories from the Floor, where healthcare professionals really gave me key learnings for changing healthcare behavior. What they told me was you have to build relationships. You can't just walk in there and do it. You have to involve champions or mentors to steer the change. You have to actively engage stakeholders and ensure that the change is desired. You're dead in the water if people don't want to change. You have to focus on seamlessly integrating change into existing practices and ensure the change message is clear and specific to particular stakeholders. Focus on the most important outcomes and indicators, but not too many. Don't rush it. Take baby steps and stay optimistic. So what we've done, given that advice, is we've taken our $5 million CIHR team in pain, and we've developed a toolkit in order to have effective and sustainable knowledge translation through what we call the development of a research knowledge infrastructure. So this is an approach to effectively and sustain knowledge translation in the healthcare system. The infrastructure needs to address the needs of various stakeholders, so it has to be multifactorial. It needs to address the needs of consumers, practitioners, managers, and policymakers. The research knowledge infrastructure can be defined as any instrument, programs, tools, measures, devices that are implemented in a healthcare system to facilitate access, dissemination, exchange, and/or the use of evidence. So this just gives you an idea. This is still under development. This will be a web-based toolkit, have 7 components. The first will be looking at reflecting on readiness for change. And if the unit is ready, then we'll really encourage them to proceed. If not, we might suggest going back to prepare the unit more. Again, the change team, the champions, the coaches, the people that are going to take responsibility for leading this change need to be identified and trained. We have ways to evaluate practices, current practices, and how these might change, and setting aims. And then we'll have options to where to focus on pain assessment or management, what valid scales might be. There will be the evidence there to support them. And finally, the pain practice change statement. And then the PDSA cycle that we've talked about, which will encourage people to engage in repeatedly until the kind of change that they want to make is attained. I just want to finish by telling you about an international organizational change initiative. And this is called ChildKind International. It's an initiative for pain prevention and management at the institutional level. It was the brainchild of the International Association for the Study of Pain Special Interest Group on Pain in Childhood. It was proposed as a joint project of this group and the World Health Organization. It was fashioned after the World Health Organization Baby Friendly Initiative. It needed external funding, it needed partners, it needed certification and monitoring, and it needed partnering with large international organizations. It started back in 2008, where a consensus meeting was held in Italy, and it was funded by the Rockefeller Foundation and Mayday Fund and the Institute of International Education. It was launched in 2010, and it was piloted last year in 2013-14 in 4 hospitals. The key principles of this organizational change is really focusing on policy, so there needs to be a facility-wide, evidence-informed written policy on pain. Education, there has to be comprehensive and ongoing education and awareness programs for all staff, students, trainees, patients, and caregivers. There has to be a focus on assessment, so all children would have pain assessed using an evidence-informed, developmentally appropriate process and documented. There have to be protocols for pain management, and there has to be evidence of quality management or improvement. Within this, we'll be able to evaluate impact at the individual, institutional, healthcare system, and societal levels. I just want to end by referring again to context, because I really think the answer is in the black box we call context. We know that there's factors within context or culture of a setting that are modifiable. Leadership, culture, evaluation, and the types of interactions, either informal or formal, between healthcare professionals are the constructs that rise to the top in terms of what might be most useful. What we have to remember is one size does not fit all. And you have to keep trying until you find the perfect fit. So I want to just close with a few take-home messages. We live within a healthcare system that is better than most in the world. However, our outcomes are not the best, and they lag behind. Research may be the answer, but it's not optimally translated into practice. There are a large number of planned KT models that are derived from different disciplinary and contextual viewpoints to guide practice change. We know that planned knowledge translation is more likely to be successful if an assessment of the likely barriers and facilitators inform the choice of knowledge translation strategies. And there's many types of barriers: structural barriers, organizational barriers, peer group barriers, and professional and patient interaction barriers. Nurses are ideally positioned to engage in knowledge translation and affect change within the changing landscape of healthcare in Canada. We need to look at implementation effectiveness at both the system level and the innovation level. And we need to know that continuity gives us roots and change gives us branches, letting us stretch and grow and reach new heights. Thank you very much.
So this is the opportunity where we invite those of you to come into some conversation with Dr. Stevens or raise a question or pose a comment. And the 2 mics on either side of the room, I am assuming, are live. So if anybody would like to test one of the mics, this is your opportunity. There always seems to be a little settling first,
a little
right?
quiet.
Yeah.
Yes.
Dr. Stevens, thank you. That was wonderful. And I think we were all quite blown away by that wonderful app. I think that's stimulated certainly my imagination about what we should be doing differently to prepare nurses and future nurse researchers and clinicians for a world in which that kind of app is the way of communicating. And it really strikes me that we don't have a lot in nursing education that really focuses on design logic. And we do lots of other kinds of creative intervention, but design hasn't been a place that we've gone. And do you see any intersections between other disciplines as we evolve that kind of capacity so that more and more of us can think of interventions that are going to have that kind of impact?
Thank you for that question, Sally. I think that what we're really trying to promote in our understanding of knowledge translation is that we need to have the key stakeholders, the people who will use that knowledge at the end of the day, involved from the beginning. And with that app, we had children with chronic illnesses tell us what was really important, and they informed the design a lot. But we also did not have the technical ability to design something like that. And so we have partnered with people that are much more knowledgeable than we are in technology, infographics, those kinds of things. But I think the key principles are that we need to really choose carefully our target audience, and we need to engage them early, find out what the key indicators are, and that will really help shape our messages. Because it's not the technology behind that. I know the technology is very impressive, and that app actually has won lots of awards. It went to the Cannes Film Festival last year. And so it's sort of the high end, but there's many other sorts of applications and technological advances that can be really linked into care. And I think this is an example of where we need to stretch our mind and creativity and be prepared to partner with other partners who can really help us get our message across.
Any other comments or questions for Dr. Stevens? Okay. Thank you so much. We are so appreciative. I think we'll all carry a number of strategies forward that you've provided us with. So we're so appreciative. And
thank you.
We have a thank you gift that I seem to have left at my seat. Colleen Barco, would you meet me halfway? So on behalf of the School of Nursing and this legacy for the Marion Woodward Lecture, we are sincerely appreciative of your time here with us all day.
Thank you so much
today. So thank you. Please join me.
Thank you.